Okay, welcome to the session after lunch. We have a very pertinent topic, transforming practice in digitalized era. So this is a very timely topic. Everything is going digital now, mainly because of the, early because of the COVID situation, now because of the fuel crisis and the increased prices in fuel everywhere, everything is going digital. So we have two eminent speakers, Dr. Dumidu Kulatunga and Dr. John Samuel. I'm sorry because I got all these details in the last moment, so you have to excuse me if I'm a little slow on introducing these two speakers. I will first introduce Dr. Gumudu Kulatunga. He's a board-certified consultant in health informatics, currently attached to the Health Information Unit, Ministry of Health, which is involved in primary care-related projects, which include digital blueprint architecture, development cluster referral, development and cloud hymns of healthy lifestyle. Clinicals has been made publications in local and international peer-reviewed journals. I'll introduce the second speaker also. He's John Samuel. He's a proud product of Sri Lanka, having obtained his MBBS from Faculty of Medicine, University of Colombo in 1971. Having started his GP career in Sri Lanka, he migrated to UK in 1977, obtained MBBS MRC GP by examination, and has been in clinical practice since 1981. Dr. John is currently a senior partner in Harrow Red General Practice, as well as clinical director of the South Lenston Primary Network. So our first speaker will be Dr. Kulatunga. Over to you. I'm sorry if I made any mistakes during the introduction, because this was given to me just 1 minute ago and I really couldn't go through it.
Good afternoon, everybody. Thank you very much for the kind introduction. Shensias, President Sir, Secretary, and the office bearers of the college, members, and dear colleagues. It's a privilege to present in this College of General Practitioners in this 47th annual academic sessions. And I represent the Ministry of Health as well as the College of Health Informatics here. So starting from the presentation, so these are the content that I'll be covering up in my presentation, but due to time constraints, I will concentrate more on the holistic picture of the digital health framework architecture in Sri Lanka and the basic theory. So actually we know that this is a new field and most of doctors don't know what is going on within Sri Lanka. So it will be very advantageous to in the collaboration on these projects. So also I will take this opportunity to build up a collaboration between the GP's College as well as our College of Health Informatics and the Ministry of Health, the Health Information Unit, in future endeavors coming to private health care, including digital health, that will enable all parties. So we know that the primary health care is increasing demand. Around 60 million patients visit OPD of state sector annually. And the GP is also visited by around 50-55 million annually, and the workload is rapidly increasing. And this growing demand need more resources and other facilities to improve the health, qualitative as well as quantitatively, cost effectively. So digital health will provide a good platform in this. So, digital health comes in a time of in 21st century, and the Steve Jobs, who always invented digital health products, always in all the devices, had made the mention that the intersection between biology and technology will be one of the biggest innovation, and it has happened. So we know that following the COVID pandemic, digital health provided large support even within GP system as well as other systems, and it enabled to save lives of the patients as well as doctors. And so what is digital health or the e-health? The word e-health had been used for last 2-3 decades, and it is simply the use of ICT or the information communication technology for health-related activities. The term digital health came later on. So it is more frequently used now, and it says the digital technologies in health. So this includes the devices as well as the systems. So the term digital health is broader than the e-health. So the topic is to find the challenges. Even the conference theme include telling me the current challenges. So what are the challenges? The WHO had found there are some global challenges. The things, the first 4 in black are more holistic to the world. It says insufficient supply of commodities, provide adherence to clinical guidelines, lack of access to information, lack of continuation of care. Those are the very common ones. Even the 2 speakers spoke earlier than me, spoke of about clinical guidelines, adhering to them in practicing asthma as well as other diabetes. So those are very important. As well as earlier, the speaker spoke of the access to information. So continuation of care, you need all the information to take correct decisions. So these are very critical factors in general practice as well as other medicine factors. So this is very important. Then when you come to Sri Lanka, due to current socio-economic conditions, there are limitations of travel for clinical as well as patients. So it's a problem, current problem. Also, there are lack of all there can be problems in finding resources, medication and services. So we have to find cost effectively and maximize the use of existing resources. So those are the most of current challenges that we should overcome, and digital health will provide a better solution on this. So these are the World Health Organization's ones I have mentioned earlier, first 4, insufficient supply of commodities, healthcare provider adherence, lack of information, and loss of follow-up. So you see that insufficient supply commodities can be overcome through information management system and logistics, like supply chain management. And healthcare poor adherence can be go through like apps. We know that at the moment country has limited drugs sometime, and like Medicaid, like antibiotics, other things can be rationally used, and we can prevent the conditions like microbial resistance, and we can maximize utilize the available resources. Also, decision-making systems will enable to prevent excess ordering of laboratory investigations. That will prevent the extra resource as well as reduce the cost of the patient in doing unnecessary investigations. Then comes the lack of information. We know for the longitudinal health records and the continuation of care, you need health records. And these health records will be supplied to information systems. And medical record and the patient registry will be catered through this. And I'll come in detail later on those, because our chief guest, Professor Vajra Dissanayake, highlighted the importance of registries. At the moment, ministries work in collaboration with Sri Lanka Medical Councils also develop those registries, and we'll be participating and taking stakeholder opinion from all the colleges, including the College of General Practitioners on this. So the 4th one, the loss of follow-up. So there can be electronic medical records and alert systems that can be helping to overcome these. Then, so drive the digitalization in general practice had been patient had been pushing the doctor to use digital, go digital, go digital. So around 10% of the Google search are health related. So when the patient come to practice, just doctor asks, what are things you can tell me about this? I have studies on the Google on this. What else you can give me? So the patient is more digital oriented and asking for more. So the doctor should be more digital oriented and use informed researches. And informed decision making is a major part. In the Western countries, we have to do it. But in Sri Lanka also now patient education is coming higher and higher. And the doctors have to update the CPDs as well as use the guideline methodologies. So, and the other thing is convert to the paperless. It's going the Western world, reduce cost. In Sri Lanka also, we are going paperless at the moment, convert to digital too. So, even though all these satisfaction of innovative health, technologies come through capacity building. So, capacity building, first you have to have human resources. So, for the digital health, the field of health informatics came through. And actually, I will express myself around 2 slides on it because health informatics field is a new field. And next slides are on this. So the health informatics field, or the specialty, medical specialty, is combined of healthcare, information science, and computer science. So the health informatics is combined of these 3 to provide maximum healthcare through digital health. So health informatics has also sub-domains: clinical informatics, public health informatics, education informatics. And those domains are expanded in the practice of public health care and hospital health care, general practice, all the field. So what we talk here is like holistic picture of the digital health or the health informatics. Then this is clinical informatics, which is more relevant to the general practice. Within healthcare, you have the curative care. Within the curative care, the clinical informatics part is there. So these are the content or the visual animation of the specialty. Then what are the digital transformation areas in digital practice? First is telemedicine, one of my favorite and which is around century old. And then health records, as I mentioned earlier. And then technology assisted diagnosis like AI management investigations and remote monitoring, e-prescribing, mobile health, online training, digital information security awareness. We know that new act came through, like digital health policy came through this year. And actually it's a very great opportunity to have those acts because with the COVID pandemic, we know a lot of GPs as well as other doctors in specialties use digital health methodologies like WhatsApp and other methodologies, Facebook and other groups. So actually it's a separate large topic to be discussed that should be explained through standards. So it's very important in practicing these proper guidelines to cover up your medical legally also. Sometimes what you express in WhatsApp or Facebook can be a litigation against you. So it's very knowledgeable to know what you are doing at the moment in this digital era. So what is telehealth? Telehealth is one of the oldest electronic health applications in the world. So it actually has a history of 100 years. So simply it can be described as a delivery of healthcare at a distance using telecommunication technologies. So that is telehealth. Telemedicine is the curative part of this. These 2 terms have been vaguely used. That's why I made a small definition of it. And the major factor is that some kind of a client, or it can be a patient or a doctor, take an opinion from another person, more senior or experienced person in the other end, who is separated by space and time, or either. So that is a small definition. So the history is, because other speakers also spoke of some history points, I also thought of telling some history, nice things. Even the first telephone call made by Alexander Graham Bell in 1876 was health related when some sulfuric acid fall his hand. But as doctors, we believe on what is said by the journals and it had been published. So even the first telephone call related to these televerse regarding a child croup in 1897, and it is a report by the Lancet. Then later but the teleword came later on with the Dutch physician with the telecardiogram. But this massive growth of tele became 1950s when the TV came up. And the telemedicine or the more specific therapeutic part came in late 1960s, and the telehealth term came 1970s, because people were earlier more concentrated on medicine part, but the holistic health part, because more than medicine part, you can do other things from telehealth, like CPD pass, you can educate others, health promote others. So there's a holistic healthcare provision through digital provide, that is called telehealth. So types of telehealth, because I will go bit on this tele part bit, because we know a lot of general practitioners and other medicines are using telemedicine as a base, they are using frequently day to day. When compared to other digital applications, telemedicine is used, because even though we don't know what you're using, this is telemedicine. I want to express though what we are using. So we have this synchronous video conference. We know there are a lot of apps are there in social apps that we use for conferencing. Then you have asynchronous, store and forward, like what we take opinion from a senior doctor or a cardiologist, pathologist. We send a slide and an X-ray and take opinion later. That is asynchronous. Then you can do remote patient monitoring. We are normally it's happen in elderly homes in other countries, I think, but even few of us don't know, but this is happening in Sri Lanka too. A lot of elderly homes are coming up with remote monitoring. And they're remote monitoring and associate hospitals. They remote most of the things of the patients who are in health homes, and they intervene accordingly. Even in some hospitals in abroad, they monitor the risk of patient falling off when standing from the bed. So the alerts comes up, and assistant goes and help. And mobile health. We know the mHealth, mobile health, usage mobile devices to help, like alerts. This is the holistic picture of telemedicine and how are the relationships. So I will go quickly as the time is limiting. So then e-prescribing. We sometimes take photographs of the prescriptions and send off. So actually we should know what is e-prescribing, what is online prescribing. E-prescribing is used in where their systems are there. In 53 hospitals in Sri Lanka, we have systems. So when a patient is consulted face to face, a prescription is made and sent to the indoor pharmacy. That goes as electronic prescription. That's called e-prescribing. Then you have the internet prescribing. That is the medical legal part. As a doctor, we practice medicine. We educate others, but medical legal part comes when you prescribe. That is like writing a deed. So that is the part we have to be careful. And here the online prescriptions are made without a face-to-face consultation, but online consultations, and then an online prescription is given. So how it gives, and where should we give it, and how should we give it, and when should not give it, it should be described in a separate, and it should be explained. There are guidelines. Actually, ministry is developing at the moment, and most countries had all developed, and there are some telemedicine registries, because early we discussed the registries. There are from other countries who have made telemedicine specific registries, because you know that according to this medical council law, only a doctor who is registered in SLMC or within country can prescribe a patient who is living within the country. So the registries are there. If someone need to prescribe for a patient within the country, he should be registered on the medical council. But there are few sections. But if not from abroad, there are separate registries still under medical council. So this is a part of it which is relevant. So on the electronic records, everybody speaks of electronic records. There are 3 types, and the wording is a bit confused. That's why I made a small clarification. We have electronic medical records, electronic health records, and personal health records. Electronic medical records, examples are these systems. HIMS, HHIMS, Cloud HIMS, all are hospital-based ones. And even GP system, there are few things in silo. I know that a lot of GP systems, and there are, I don't like to trade the trade names, but a few systems, commercial ones, you can install in your GP practices, as well as few small hospitals, nursing homes. Those are which run silo, and within that institute, that is EMR. And the critical factor for interoperability is that you have to use a PHN, personal health number. I'll explain it on the next slide. That is a part of it. Then personal health record. This is like what you make a record like a personal file. Like a patient make his own file, physical file, and bring to the doctor. Here there's a collaboration between the GP and the patient, and there's a content are being shared. and the electronic health record. This is the one which shared information with one system to other, and this is made from birth to death. And these are interoperable systems, and we are actually making this such system in our digital, what you call digital blueprint. These are the few of the technologies that we used. You know, the one kind ICPC3 is there, so we need to collaborate in those, and the College of General Practitioners and the ministry and our college can make collaborative effect in making these IPC3 categorizations in terminologies. Then what are the advantages of EHR for GP? So, the doctor is able to get the complete health information regarding the patient. We know when digital prescribing, when you are prescribing controlled drugs, you have to have a drug history. Without a drug history, because this is regarding other countries, developed countries, where they have laws on related to telemedicine. We are actually making at the moment, and our laws and guidelines will come to like this. When you are prescribing through systems in controlled drugs, you know what is controlled drugs? That should have a patient should have a history, past history. Only if so we can prescribe. So this information is available through system. Then you have quick access and more coordinated care. You can have early diagnostics, and you don't have repeat tests. The tests done in the last GP or the hospital will be available to this GP, and the data will be secured. It won't be running around with a file, and there can be reduced cost, and the convenience is there because system like telemedicine, patient can get treatment from the home, and the doctor can treat from the home too. So there are other things like fewer wearable devices that will go through quickly because of time. mHealth is mobile devices. Then what are the advantages? Advantages comes to patient as well as provider. Provider gets advantage of increased flexibility and ability to do consultation from convenient place, and ability to get support from the specialist. You can get a second opinion, and patient can follow up easily, and you can expand the service area. Specialist, the classic feature of telemedicine is that from primary care GP can, without going to the referral system one after the other, we can take an opinion directly from the who is in the central point and take opinion and give treatment. In the patient side, you have a lot of patient convenience, saves times like that. The time I will go through. This is the architecture of Sri Lanka. It will be very important to you to know what is going on in the country and how you, the college, can contribute, as well as the members can contribute to the digital architecture development as well as expansion of services. So this is Sri Lanka. 600 square miles, I think it's expanded with the new projects, and the population at 22 million actually, and low middle income country. We have doctor ratio of 1 to 700, and we have clinics nearby. But even though such, we try to take opinion from using technologies. Even though clinics nearby, we take opinion of technologies. And our literacy rate very high, mobile usage around 140%. We have electricity almost time coverage, and we have specialty, and elderly population rising. So those are the facilitating factors to expansion of digital health. So these are the overall applications that work. I won't go quickly those things. And these are the main programs that I need to express that going on the ministry. We have digital blueprint development. Digital blueprint is the overall architecture of the healthcare delivery through digital health. And the college can contribute for this architecture development. Also, we have a cluster system for the primary care. And the primary care system strengthening PCT project on cloud HIM, that is healthy lifetime clinics. Those are the three main areas that will be directly involved, which digital health and the college. Then the cluster system. Actually, this cluster system came a few years back. It's more like more referral system. And each cluster has one institute. Sorry. Thank you very much. And each cluster has one Apex system, and there are referral things. And so each referral primary care institute refer to the cluster Apex. And the system is called this cluster system. And this is funded by ADB. So these are the first two stages. This is the Dambulla, second Tambuttegama. These are the first pilots, and there are other 7 more to come. So these are the digitally ones. So we are showing the ones, and this will be referral back referral, and there will be a time that primary care physicians as well as the GP college can contribute to this. And this is Cloud HIMS. Cloud HIMS is the one for the HLC, Healthy Lifestyle Clinics, and there are around 400 clinics at the moment. And this is the overall picture of the hospital systems I told. I'll take 2 minutes more, right? And because actually it's a gross picture, it takes long time, not a specific one. And we have 51 hospitals called HHMS, and second HIMS 12, and the Cloud HIMS that is 400. And up to now, V100 actually registered around, you say 5 million, around 9 million patients had been registered in those systems. And this is hospital information systems. And what I informed earlier, HIMS, HHMS. This is the overall distribution of those systems. And the important point is next, that is important to our college, the College of General Practice, is that issue of this PHN number. This is a key number, like a NIC, because we know that above 18 years only we get the NIC. So how do you track a patient which is below 18? This is through PHN. Now the new hospitals are giving the PHNs from the birth. This is the key, primary key that can be used, this 11-digit one, to get it. Even your system can be registered in the Ministry of the Primary Health Care and the Private Medical Regulatory Authority, and get a POI. From the POI, you can issue the numbers to your patient, and it will be a main interoperability factor in the future to come. These are the overall picture of all the information systems that is working in the private sector as well. I think what you most know is the COVID-19 home-based care, where the college had been contributing to collaborate with the ministry and looking after the patients using telephone calls from home. It is a great opportunity. And this is the architecture. Here you can see that the mouse is not working. You can see that the preventive, the curative is there. The important registries are there, what you inform. And the bottom you have this PHR. So GP systems will be collaborating with the longitudinal national health record mentioned here. Record, and it will be, the systems data will be interoperable between GPs and hospitals in the future to come. This is the registries. You have 3 registries. One is a client registry, that is a patient. Second, the provider registry. Provider registry, you have section 29, 39 for the specialist, and you have other categories like PHMs, you have these pharmacies, laboratories, all things. So all those are registries. So it will be developed in the future, and there can be institute registries. So institute registries, early at the moment, HIN number is given to the government ones. Later it will be expanded to the private sector too. So this is an overall picture of, now you see there are a lot of things we are doing, not doing it properly to collaborate. But this is the overall picture. You Cloud HIM is for the primary health care, the cluster, then HN hospitals, and both joined together with the digital blueprint will give a joint health sector expansion. And these are the few legislations we'll go through. You don't have to go through those. Those are things that you have to consider while treating online. And sorry, and it's going on. These are the standards. And these are the few of the COVID applications that are happening in the country in the COVID, and a lot of digital health activities happen there. These are the few, I will go to 1 minute for this, the challenges. When challenges, even though people use phones 140%, but their broadband connections are 50%. Only half have broadband. That means apps are available only 50%. Only the moderate, that is there. Even moderate literacy is moderate. And there's kind of digital divide, and elderly people are a bit reluctant to use digital devices. Or some doctors are reluctant to it. And the other thing is lack of guidelines. So, but we will be catered and overcoming that soon. And the way forward is that we'll discuss with your colleges and other things, and you have been will be invited in the future to collaborate, pilot those tests in the G practices, and we'll be collaboration between two, and you can request the POI numbers from the HIU in the ministry if you're having own digital systems. And it will be duty for all of us to collaborate together and to make sure proper health and expand the Sri Lankan health status using digital health. And all your opinion will be important in the future systems to come. Thank you very much.
Thank you, Dr. Dumidu, for that lot of information given on digital health and telemedicine. I will take the questions after the next speaker. I would like to invite Dr. John Samuel to speak to us about the same topic. Over to you, sir.
Hello, I'm Dr. Samuel. Hope you can hear me.
Yes, we do, sir. We can hear you well.
Yeah, good. Greetings from UK. Just a few introduction about myself. I qualified in Sri Lanka in 1971 from Colombo faculty. Did my internship in General Hospital. Worked in general practice in Sri Lanka in LPT and Ratmalana. Came to UK in 1977. Did my vocational training and did the MRC GP. And I'm in clinical practice since 1981. Currently a senior partner in a practice and a clinical director for Leighton Stone PCN, which is basically a group of general practice. Let me first and foremost tell you that I am a practicing GP and I am not an academic, nor I am an expert in digitalization. All what I am trying to tell you is my experience in UK as an immigrant GP. And I just happened to listen to the tail end of the previous speaker, and I'm quite happy to see the way they are progressing on this digitalization. Start off from an NHS point of view. In UK, I think my first slide shows what you call Lloyd George envelope, which have been studied in UK since 1911. This was the beginning of keeping proper medical records. When the doctor writes the notes and puts it in the envelope, and the envelope is sent to the central place, from where it's sent on to another GP. This is how the sort of the continuity of the care from cradle to death happened in NHS. And this is where I started when I came. I started using this as the main form of communication, where all the consultation and clinical information is written on it. Then, as I started, fortunately for me, the computerization also took on in a much bigger scale in UK, and invested on a simple, straightforward desktop computer, and started using it on primarily to put on vital statistics, and gradually on to consultations and medication and the rest of it. And as the practice grew, we had more than one doctor. So naturally, the surgery became a bit larger, and we started connecting with the other doctors with a form of hardware connections. And this is how we started communicating between the GPs. Then with this came the internet revolution, and that completely revolutionized the whole way we communicate now. And that's how now we are trying to get on to the next digitalization. With internet and the digitalization, the whole world has become a village in a sense, that we are communicating with one another, and we should do it from day to day life. In fact, about 10 or 11 years ago, when I came to do a presentation, I came over there and did a presentation. Today, I'm sitting in my consulting room and talking to you, which is such a great opportunity. So let me then start off with the next room slide. See how the whole consultation in this country has changed. Here is a physician, and the other side of this is the patient, but the central is the screen. So now the consultation involves the GP, the client, and the computer. We are all in one room, and the computer plays such an important role in our day-to-day communication, and is shared by other people. So the whole concept of the consultation has changed with computer digitalization. Along with this came the converting the language we speak into digital form, which is basically what digitalization means. And then this forms the coding system. And with the coding system, we are able to communicate much more effectively, and with so many other things underneath. Everything what we write is coded, and with that code, we are able to transmit, audit, inspect, and reward. So many systems. And now, of course, the coding system has become almost an international coding system, and I'm sure experts will tell you exactly what it is. But I will just concentrate on what I do in our practice. So if I can take to the next slide. I will basically start by saying, how do we use the computer? So when we see the computer, when we sit in front of a computer, we have this whole thing exactly starting with the consultation. We have got the problems of the patient, what the patient's problem is, and we have got a full data of what it is. And the consultation goes in the usual way as we normally do traditional thing, which is basically history taking, examination, investigation, and formulation, the usual thing we are all used to it. So that's how the consultation starts. So, and that does not change. We only thing we make the entry on the computer. Then I did also listen to the way that the medication was issued in Sri Lanka, and I think that's another important issue in our country where we do the medication. Of course, there are lots of rules and regulations about how we issue medication, control, etc. But just to know that from a point of consultation in our computer age, we have a good record of what medication we are using and what medication we should be using and how we should be medication. In addition, when you see the next screen, it will tell you when a patient comes and sits, what are his problems are. So we have an idea of what his past history, what his current problem is. At the same time, it tells us what medication he is on. And also by linking, we can know what medication given for what reason. In addition to that, we have the latent health status about the patient's usual health screening status, about his height, weight, and all the things that goes along with it to tell about the patients. That's the health screen slides. And then comes the investigation. This investigation is quite an interesting data. Yeah, that's it. For example, yes, I think got that slide. Yes. The slide may not, yes, but it's the slides. The investigation tells us all the sort of the radiance, blood counts, and all that. For example, I'll quote one example. Say, example, a diabetic is in front of you, and you would like to know what your kidney function is. So, over a period of time, we can track his glomerular filtration rate for a number of years. So, we really know how the kidney is functioning and when to interfere and when not to interfere. So, these are communication we can use in our day-to-day practice. And the investigations are linked to the labs. So we get the results directly from the labs and we are able to get the information straight away without waiting for any delay. So through the internet, we are linked to the labs as well. In addition, we do the referrals. Now, I think this is something which we do it with the primary care and secondary care in this country quite routinely. And the referrals are not only sent to the hospital consultants, but we also do referral to, wish I could share the computer screens with you all, but unfortunately due to limitations of the confidentiality and other software rules, I'm unable to do that. But it is something worthwhile sharing. And the referrals we send it, for example, now we have developed a full primary care team. So that means it's not only the physician, but we have got other ancillary staff like the nursing staff, physiotherapists, counselors, mental health practitioners, and a whole heap of other people are joining the team. And we are able to communicate with one another. And all the entries made into the same computer, and we have a comprehensive record of what's going on. And then, of course, from a patient's point of view, how do we communicate with the patients? Now, of course, the patients, the patients are making their own appointments, and we can inform them of their appointments. Not only we can inform of the appointments, they have access to the computer records, so they have an informed of what's going on in their own language by looking at the computer records. In addition, we can send leaflets or electronically. Say if somebody is diagnosed as a new diabetic, for example, we can send either a web link or a leaflet about diabetes so that we can educate them in the way they are doing it. And informing the well-informed patient is obviously and look after himself, and self-care becomes much more effective. And another important aspect which we have to appreciate is, since we have the coding system, all the data is stored. And when the data is stored, it becomes very easy to do audits, how we are performing. And when you do the performance and what we do and find out what is missing, by audit, we can continue to innovate and creativity comes in. With that audits comes the innovation and creativity. And of course, needless to say, the amount of data is so vast, it's a gold mine for research from an epidemiological point of view. And obviously, it forms an extremely useful thing to do research. At the same time, it's worthwhile mentioning from a public health point of view, we have got so much data, this public health data becomes much more interesting. And then of course, having said that, all the work we do has to be monitored. And here we have the CQC Care Quality Commission, which keeps an eye on us as to how we are performing what we are supposed to perform. And that is certainly is very, very important point of quality control. And another important aspect, of course, anything is undoubtedly cost. And the business aspect of the practice is another practice which we need to pay, because at the end of the day, everything costs money, everything has to be paid back, and everybody has to be audited. And now, of course, the payment is not purely on quantity, but also we are paid by quality of the service we offer. Not only the number of patients we look after, but the way we looked after is measured very closely, monitored, so that there's a general improvement of a holistic care. And I would like to end up by just telling one thing. The practice where I practice now for the last almost 35 to 40 years is a very socially deprived area where there's a different level of education, people from all over the world with different languages. In fact, for almost half the population, English is not their primary language. Different faiths, different culture, and yet the care they get is completely uniform. So in other words, digitalization has facilitated in providing a uniformed care in a holistic manner, incorporating both physical, mental, and social care. I think it's really a wonderful thing to do, and wish we could promote this to everybody around. Thank you.
Thank you, Dr. Samuel, for enlightening us about the British mode of keeping digital records and how we also could proceed. Thank you very much. Now the floor is open for questions from both the speakers. Can I begin by asking one question from Chair, from Dr. Dumindu? I just want to know whether, now when we give a prescription through a digital way, is it legal? Can we give actually a prescription through WhatsApp or a computer sort of program? Is it legal, or could we be charged for giving that? I mean, is it legal to do that?
It's a very important question because we are covered by the Electronic Transaction Act 2006. Actually, I showed few of the acts there.
Yeah.
So the law actually covers as electronic electronic document, but content inside it should be doctor's responsibility. But that's why we are going to develop few guidelines, and the moment at the ministry at the moment is developing them. I am heading it, and on that only we can guide where to prescribe and whom to prescribe. And so some conditions we can't prescribe online, like conditions without information, like controlled drugs, few conditions that needs, like small children, you can't do it. So there are few guidelines. India also developed last year. In the COVID pandemic actually led to a rapid boost of the development guidelines. We were a bit delayed, but we have already made a few rational but not published. We are going to publish in the recent future. And so come to the question directly, it's your own responsibility. It's like what you send in the right.
Yeah. So if we have given a right prescription, then it's not offense.
Yeah.
That means we have the legal right to prescribe digitally.
Yes, we have to, because we have to, but not as SMS. Because sometimes I have seen people putting SMS.
So what we have to do is we have to write the prescription, take a picture or scan it, and send it.
Send it, yeah. But the only issue is in that there can be chance of repeat prescriptions. That's why even my prescriptions I put below cannot be repeated without putting the date. So the pharmacy should not deliver drugs to old ones. Even NHS, I think I will confirm from my UK colleague that you can repeat prescriptions to a certain extent. But in Sri Lanka, because pharmacists are not adhering to guidelines and not doing, they are giving drug after 1 year. Sometimes you can see the practices, they are coming after 1 year. Sometimes they being prescriptions, WhatsApp prescriptions in COVID time, and asking doctor, this is well taken, now shall I continue with that? So I asked, who would prescribe in a doctor? In your close, no, the people prescribe, I am continuing. So like continuation of a NCD drug, other drug, how safe it is. But the safe is that you put a message also. All record can be recorded, but still you are safe, they'll put a message.
Have we got to mention in the e-prescription that it's a e-prescription? Have you got to say that?
No, e-prescription made if you made through a proper electronic system. Now we are actually using out, WhatsApp, other things.
Yeah. Have you got to write in that prescription, this is patient was...
No, actually image, because we can't trace what is going on. Even the patient can take a photograph of the physical one and send to another person. So a bit different, you have to have the TRC to who had started digitalizing is. It bit different. If you come medically, it will be a big process. But some process, sometimes you will save, you write within written also. This is done following a thing. So you are covering up as same as writing medical certificates. So you can write it openly, but still you can write it with few terms. So even though a person can't say, no, you have all written. So you are on the safe side.
Okay. Then in the absence of any more questions, I thank both speakers. And yes, and we have to give token of appreciation.
I would like to invite Dr. Sanath Hettige to hand over the token of appreciation to Dr. Gumindu Kulatunga.
Okay, thank you. Our next topic is minor surgery in general practice, which will be done by Professor DJ Anthony. And this is also a very timely topic because we get a lot of minor surgeries in our day-to-day practice. And we are a little reluctant to do minor surgeries in our practices. And we sometimes always tell to go to a surgeon. But a lot of our patients tell us, doctor, can't you do it? They'll be very grateful if we could do the surgery for them. So it's great if you could learn more about this and if we can practice to do our own minor surgeries. And Professor DJ Anthony will be introduced.
Thank you. Professor DJ Anthony, MBBS, MS, FRCS, FCSSL. He's a consultant surgeon and professor and head of the Department of Anatomy in the Faculty of Medicine, University of Colombo, Sri Lanka. And Sir graduated from University of Peradeniya, postgraduate qualifications from PGIM Colombo, overseas training in Princess Royal Hospital in Farnborough, Kent, UK, and also UK training on breast and colorectal surgery. And he's a former president in the Anatomical Society of Sri Lanka, chairman in the Basic Medical Sciences in PGIM, served as a member in Board of Study in Radiology for 6 years, a postgraduate trainer in general surgery, ophthalmology, obstetrics and gynecology, sports medicine and so on. And he has been an examiner for Royal College of Surgeons in England for 15 years. And he is the immediate past president of the Arts Council of University of Colombo. If we are to talk about his hobbies, he's a vocalist in Sri Lanka Broadcasting Corporation, has music albums of his own compositions, guitar and keyboard player, and member of the audition panel for the light songs in the Sri Lanka Broadcasting Corporation. Over to you, sir.
Thank you very much for those kind words of introduction. Dr. D.K. Matthew, the President of College of General Practitioners in Sri Lanka, Council members and my dear colleagues, I am sincerely thankful to you all. Please accept my sincere thanks for inviting me to deliver this lecture. And it's going to be a very brief one, and we'll catch up with the lost time. Right. So,
take the time allocated
no,
for you.
I don't think I can go beyond 45 minutes because
Okay.
I know
No, that's
people
okay,
cannot
yeah.
concentrate for more
Yeah,
than
45 minutes I think should be.
Yeah, that's fine. Right. So, when you talk about the minor surgical procedures in general practice, it's very important for you to know, for you to understand what cases to accept and what cases not to do. That's a very difficult decision sometimes. You know, they say the surgeons, even for surgeons, the surgeons know how to operate. The good surgeons know, or the better surgeons know, when to operate. And the best surgeons know when not to operate. It's a very difficult decision. But, you know, let's make it simple. First of all, let me tell you, yes, should we do cold cases? I mean, the elective cases like uncomplicated sebaceous cyst, lipomas, and small surgeries. Yes, I think we should. Right? We should accept those cases, provided you are confident enough to do the surgery. Right? It's the confidence which matters. And I'm sure all of you are confident in doing these minor surgeries without any problem. But certain things should be, you have to have some requirements if you are going to do a surgery, minor surgery. Even a minor surgery, you should give due respect. So, a good table, separate, dedicated table should be there for wound dressings and operations. Table height matters if you are standing. When you bend your elbow to 90 degrees, that's your comfortable height. The table should be in that height. That's the most comfortable height. If you are seated again, no problem. You have to lower the table to that height. That's right. So that's the most comfortable. Otherwise, we struggle even for a smaller thing. Right. And then chair you can adjust according to the height of the table. The requirement is elbow bend to 90 degrees. Light, please make sure you have a dedicated spotlight. That is very, very important. You might be able to operate with candle light. That's a different thing. But it makes a huge difference, and it makes your life very comfortable when you have so spending on a good light, it never go waste. So please remember that. Well, the other things are autoclaves and rapes, sutures and instruments and things. I don't think I should go to those details. Those are very basic things. And then about the emergencies, very often you get simple lacerations in the body. So you can handle most of those things, but certain things should be remembered. If you get a minor laceration, even a very minor laceration on a limb, please do check for the tendon. It's very important. Check for the tendon, check for the nerve. Because if you miss it, it's difficult to repair those things at a later stage. So please, if it is on the extensor side, please ask the patient to simple test, extend and see. That's it. If it is on the flexor side, just ask the patient to flex, especially you have to, not the flex, even the distal phalanx, you can just check like that because there are two tendons here, the superficialis and the profundus. Right? Profundus, you have to check, you have to hold it and ask the patient to bend the terminal phalanx. Right? So, be accurate. So, if there is a tendon injury, if you suspect that there is the slightest possibility of tendon injury, please do refer the patient. Never try to do anything there. You can't. Then tendo achilis, often people miss that. Even a slight glass cut will definitely, 90% of the time the tendo achilis is cut because it's very superficial. It's so superficial. Skin and the tendon. So I would personally not attempt any tendo achilis over the tendo achilis. If there is a cut, straight refer. Please don't do that. Then the other, what about a laceration like this? Can you suture? Yes, you can. Only thing is, skin is the toughest layer when you take skin, subcutaneous tissue and the muscle and things, and then the bone, periosteum and the bone. Skin is the toughest. So if you break the skin, invariably the muscle is gone. Very often muscle is gone, which we don't realize. If the muscle is gone, you have to suture the muscle separately. And then, so that's what I call layered suturing. So you have to use a absorbable suture like polypropylene, like Vicryl or right, whatever it is. Often we use Vicryl or monocryl or whatever it is for the underlying muscle, and then suture the skin. So don't take it lightly and don't take the entire thing together. That's very important, right? Especially on the face, because then what happens is if you don't suture the muscle, it leaves a very ugly scar, right? And this is a very common condition you get in general practice, chin laceration, small children, right? And especially small children under 8 years of. Normally, I will never suture under local anesthetic children under 8 years. It's very difficult. They struggle. They struggle not because of the pain. They are scared. And you can't do a proper job. You lose your temper and patience, everything. So, why all that hassle? Just refer the patient. Right? So, but now if you really want, well, you can suture. Might get some marks there, suture lines. Any alternative? We have this wonderful rug. It's tissue glue or tissue adhesive. It's acryl something, some gel. The moment you put that and hold the edges together, within seconds it seals, and that's it. It doesn't take even 10 minutes for the job. You can use, it's a wonderful rug. Commercially available preparations are there in Sri Lanka. You can buy from various places. Once opened, you can keep it in the refrigerator. I used to do this when I did general practice. Well, I was a general practitioner for about 25 to 30 years myself. So I used to do this about 15 to 20 years ago. One of the pioneers to use this. Because my boss is the pioneer the person who imported that. So he wanted me to try this on patients. It works very well. Only thing is if the underlying muscle is cut, never to use that. This is only for the skin and the subcutaneous tissue. If the muscle is cut, you can't use this. The only problem is it takes only 5 to 10 minutes and only 2 drops. And charging is a problem. Because at least you have to charge very, very, I mean, you save a lot of time, patients' theatre time. Otherwise, you have to take the patient to a theatre and do this under general anesthetic. You know the costs involved, right? And these things are expensive as well. You have to tell the patient and charge. Right. And some people, the same thing, you might question whether you can use steri strips. Don't do that. Hopeless. it just gives way. I never use steri-strips on gaping wounds, right? Especially when it gets wet with blood. No. Alternative, yes, there is a very nice alternative. Sorry, I haven't got the picture of that. You know Mefex, that that adhesive like elastoplast. Like elastoplast, the 3M produces that white elastoplast, that's Mefex. And that is like, like Hakobond. So what you can do is, you can have small strips like steri strips, get it autoclaved, keep it safely packed, and about say 3 by 2 centimeter like, and you can, even after suturing you can do this. You can, like you put steri strips, you paste one end and then stretch it and then paste on the other end. And after that you keep it for about 14 days, 10 to 14 days, and straight away open it. It's like tissue glue. It's very effective. So don't use steri strips and use that one. What about, this is an extreme case, dog bites, there's animal bites. The traditional teaching is not to suture animal bites. Well, it has. Now it's not so. We do suture. Primary suturing you can do. Only problem is you have to cut the edges, because however much you wash with normal saline, you can't get rid of that dirt and those germs and everything. It's a dirty wound. So if you cut the edges right up to the depth, the full depth, and then suture, it works. Even other contaminated wounds, I do that trick. I cut the skin edge and I deepen it up to the base of the wound and then suture, no problem. The other thing is, when you get a laceration like this, it's macerated tissue. The tissue is not healthy there. It's a macerated tissue. Macerated tissue, if you suture, it doesn't work that way. So you remove that unhealthy tissue and then you get a clean edge and suture, no problem. And often we use adrenaline plus lignocaine, because then the bleeding is minimized. This is what I told you. The skin, when you take the skin, all those superficial layers, no problem. You can suture without any problem. But if the underlying muscle is cut, you have to suture muscle separately. Otherwise, the tension is more on the wound and you might get a keloid, ugly scar. But if you suture in layers, scar is very neat. Scar is very nice, very neat. Yeah, this looks like a sebaceous cyst, no? Rather sebaceous abscess. This type of thing easily you can do. Mind you, when you give a local anesthetic to these infected things, it takes a little while for the local anesthetic to work. And if you are a good clinician, your local anesthetic should work beautifully, and then patients shouldn't scream at all. But tell the patient that the touch and the pain are different things. Just before coming here about few minutes ago, I just did a circumcision on a very young patient, 25 years. And very often, the surgeons don't like to do circumcision under local anesthetic, young patients, because they scream unnecessarily. So I had to virtually threaten him, right, not to scream, because unnecessarily he was screaming. So, and the other thing is, you give the local anesthetic and see another patient and come back. Give enough time for the local anesthetic to work. at least 5 minutes. Right? Because the first instance, if the patient feels pain, even for the touch after that, he will scream. So give enough time. There are two ways of giving locals. You can just give it under the skin, just under the skin. That's called raising a wheel. Raising a wheel. It's a bit painful. It's a bit painful because skin is very sensitive. But beautifully, the anesthetic, after that the anesthesia works very beautifully. Right? And for abscesses, I do that. I just go, because you don't want to inject into the abscess cavity, it doesn't work that way. So you have to inject just under the skin. When you raise a wheel, the skin elevates like a peel of an orange, and you get those little, it becomes white. You can see that. It's a bit difficult to inject just under. That's called raising a wheel. That's the best thing if you are going to do an abscess. And after that, you can infiltrate in the surrounding area. The other thing is just go under the skin, but not for the abscesses. So these kind of things you can do. What about this? Yeah, diagnosis, not just abscess. It's a carbuncle. It's a carbuncle. You can see different spots, like pustules. Very often you get it in the nape of the neck or back of the chest. Never attempt these things. You can't. You just can't do this, carbuncles. Never touch, because you have to make a very deep incision. It goes about 2 centimeters into the dermis, and then under the dermis, under that fascia, you have to go right round, and the pus has gone into the tissue planes. You can never do these things under local anesthetic. So carbuncles, please don't. And don't treat with antibiotics. It's carbuncles, when you do it under general anesthetic in the correct way, it heals beautifully, and we suture. Primarily we suture. We never keep these things open now like those days. This is also a carbuncle-like thing, but more than that, I think it's a localized abscess. Right? In the internet, it said carbuncle. It doesn't look like. Even if it is a carbuncle, it's a small one. You can easily infiltrate around and get a good cleaning here. I think these so the olicranon, I think. So it depends. A small thing like this, and you can see the surrounding area. You can feel if it is tense, and if it is a localized thing, still you can attempt. This is another problem. You might get, very often you get prick injuries to the hands and soles. You don't know what to do, because you can't explore the wound, it's difficult, and just a tiny wound, patient doesn't see, patient will say, small prick, why do you want to cut? Right? But the problem is, if you get an infection, it's going to be a deep-seated infection. And hand injuries and the sole injuries should be treated in due respect. Often they need admission and IV antibiotics. They need IV antibiotics, and the slightest doubt about the infection, you have to explore the wound and open the wound, because you don't know how far it has gone. And if it has gone to a tendon sheath, it's very difficult to manage, because it goes either way, right? Both ways, proximally and distally, and big cuts have to be made. So if there is an inevitable delay, like COVID period or something like that, if the patient cannot go on the same day, start them on very high oral antibiotics. Say, I normally put them on clindamycin and give a high dose like 600 milligram 8 hourly plus flucloxacillin. That's a good combination for Staph aureus. Clindamycin and flucloxacillin. Even for community acquired cellulitis, I use the same combination. It works very well. So prick injuries are a bit tricky. When you select a case, now this is in the face. I don't think in the general practice we should attempt at these cold cases in the forehead and face. Right. Scalp, no problem. Right. Scalp sebaceous cyst, but be careful. Sometimes aneurysms are there, just mimic sebaceous cyst, and the lipomas are. They feel is just like a lipoma, and no pulsations. But when you go to do that, you realize it's something else, and it can happen to even us. Right? With so much of experience, recently a general practitioner referred the case, a small lump on the forehead, very small, circumscribed, very nicely mobile. Right, and the patient didn't have that much of money, so I took him to the dressing room, gave a little local anesthetic, and cut it. Started bleeding like mad. It was bleeding profusely, and I was not prepared. So used all my techniques, and then somehow or the other removed the lump and got away. So that's a good lesson to learn, because I should have done an ultrasound scan there, right? Even if then confirm that it's a lipoma. And the histology came as hemangioma, completely excised anyway. So got away. So don't get into those problems in the general practice. Never. I will discourage you from doing those things unless it is a confirmed sebaceous cyst in the scalp. If it is not pulsatile, yeah. Even if you miss it, and if you get into a mess, all you have to do is, if it is a circumscribed this thing, get some deep sutures and then tighten it, and you can refer to a surgeon, no problem. After that, you must know how to get away also. Just get some deep sutures, that's it. Right. 2 or 3, that would do. So, face and the scalp, better not to do. Right. Yes. This I did it in the OPD clinic. This patient had a little lump. You can see it's like a berry. Had an injury, small injury, and then it bleeds after some time. And she got this lump following an injury. It got infected a little bit, and then got this lump. And when you are operating on the face, it's a good technique to keep the hair away. Put some microplasters, or you can put some gel there. So that was a pyogenic granuloma. I would say not to attempt those things. Right. This is ingrown toenail is a frequently encountered problem in general practice. I'm sure you can do those things if you know the principles. So I thought I'll take you through the steps. Just see, you have to give a ring block. Ring block is a very, important thing in general practice. Often you get abscesses, tiny abscesses and things to be done in, in the pulp or fingers, toes. So you must know how to give a ring block correctly. What you need to realize is, what you block is the digital nerve. You can see the digital nerve is placed very anteriorly, not dorsally. So you have to take the needle and infiltrate the local anesthetic. You have to go past this line. Can you see a pigmented line? If you see your own finger, you can see there is a pigmented and non-pigmented border there. It has not been described in anatomy books or surgical books, and I described it for the first time about a couple of years ago. So, and I described the digital nerve in relation to that border. So if you go past that border and go right beneath the flexor skin, palmar skin, then you are at the correct place. Then you infiltrate there. Right. Sorry about the quality of these videos, but I'm sure you can see. You can see that I'm injecting and I'm going right to the palmar side. Oh, so to the other side, and sometimes I do this. I keep my other finger and feel for the needle tip. You can see the needle tip approaching the volar skin surface. But that's dangerous. Don't do that, because I myself have got 1 or 2 needle prick injuries, because the patient does this and then needle comes and it pierces that skin and hit your skin. But you can judge, right, the depth. And this is the way to avulse the nail. You have to, you saw that, no? How the nail is avulsed. You have to go really up to the nail root and then avulse it. Very nicely it comes. Oh. So after doing that, hang on for a second. Then you have to clean the nail bed very well. You have to remove all that dead tissue. That's the most important thing. You can see that I am cleaning all those things. And then I take the scalpel and I cut a wedge. You cut a wedge right up to the bone. And then, the nail grows about 1 centimeter. It starts growing from a point 1 centimeter distal to proximal to the nail bed, the nail aponeuchium. You call it the margin. So I go beneath the skin and destroy that area. I take that. You can see my scalpel goes under the skin and I take that root of the nail. Otherwise it comes back. And do it in the first go, then, and get rid of that dirty tissues and everything. And then what I do is, I clean that and I bring that flap and paste it onto this side and put a nice, no sutures, no stitches, nothing. I'll show you how to do that. Still I am cleaning there. Then you have to wash it nicely. These steps makes a big difference, because you don't leave any dirt there. Your healing is perfect. Can you see when I press there, it just comes closer. There, then the bleeding stops. There you are, then the bleeding stops. So what I do is, just observe what I do. Right. Now you have to put a little piece of gauze. Okay, that's done. Now you have to remove your gloves, otherwise you can't put your plaster. See how yeah, got it there? I just pulled the plaster and then anchored that into this side. Now it won't bleed, just holds. That's it. No bleeding, no sutures. Then you do this and you are going to keep this for a week. 1 week or 10 days later, you just remove it, that's it. No dressings necessary, perfectly healed, no pain, that's it. So, yes. So, you can attempt these things in your general practice. It's not a big issue there. So, okay, we'll go to the next and just put 1 or 2 plasters, that's it. I normally don't put bulky dressings and things. And this won't bleed at all, no bleeding. Then you might get infected wounds in your practice, diabetic wounds, right, or non-diabetic. And when you, diabetic wounds, of course, no problem. You can cut your slough there, right, without giving any local anesthetic or anything. This type of a thing, no local anesthetic necessary. And it's very important when you are removing slough, just angle the blade and keep onto the correct tissue plane. Surgery is all about correcting correct tissue plane. And what you see underneath that yellow stuff, that's not slough. That's just the tendon and the subcutaneous. So don't cut that. Just remove that, and because when you keep these things, the bacteria gets collected underneath and then can get infected. It's always better to cut the slough and the dead tissue. This is without any local, and that's it. I forgot to mention about the foreign bodies. Often I have seen GPs attempting foreign body removal, and you must know what to remove, what not to remove. If you can feel the foreign body, or attempt only if you can feel it, only if you can feel it. If it is very superficial, give a local anesthetic and take it out. Never try to explore. It's very difficult. Even we do fail in sometimes in theaters. Foreign bodies are very tricky. So if you can feel the foreign body, yes. And if it is not in a very, if there are no vital structures and underlying vital structures, you can remove those things. So that's it. Thank you very much.
Thank you so much, Professor Anthony, for that very informative presentation, telling us how to do some minor surgical procedures, what to do and what not to do, and what we should refer to surgeons. If there's any question, Professor would like to answer. No questions? Okay, I have one question from Chair. Sir, now a lot of people, when they get deep prick injuries, as you said, we don't know whether there is any foreign substances inside. And that can, as you quite correctly said, I have seen a lot of infections coming. So how could we know? Is there any way, unless...
Very difficult, very difficult. Best thing is glass cuts. Invariably there are, small things inside and it has gone very deep. Glass injuries are very tricky. Best thing is to refer those things, never attempt. And this knife and these sharp objects, sometimes penetrating injuries, it's difficult. It's very difficult to see whether, because even if you do X-ray, no point, you can't see very often. So what I do is sometimes, if you are fairly certain this is a fairly clean prick injury, what I do is I give a good, like clindamycin and flucloxacillin, antibiotic dose, and review the patient after 2-3 days. If there is nothing, no pain, no signs of infection, okay, you are through. Otherwise, you will have to refer again. That's okay. You can refer later for exploration. On the very first instance, you don't know. It's very difficult to say. You can't.
Okay, sir.
It's trial and error like.
So I have a question. Regarding these lip injuries, is it safe to suture
Regarding?
lip injuries?
No. I think facial injuries better not to handle because you can't get these keloids are very common. For your bad luck, patient might get a keloid and then will blame you. It's not good. I think I will discourage. Facial injuries, be careful. Better not.
Excuse me, what is your experience in the nails pricks through through the slippers?
Yeah, it's a very common thing. Through the slippers, nail pricks, especially diabetics, because they have neuropathy, they don't know. Even otherwise, if it's not a diabetic, it's not a big problem because the diabetics, it really goes in and it goes unnoticed for some time and they end up sometimes with amputations. Yes. Sometimes, yeah, I have had 1 or 2 cases like that. I have discovered rubber pieces driven into the flesh. Wound never heals. So any prick injury, any wound should heal. The bottom line is wounds I did not discuss today. Any wound should heal. If it doesn't heal, there is a problem. So normal prick injury to the sole, if it is not a diabetic, that wound should heal without any problem within a couple of days. If it doesn't, that means there is something. So in that case, you have to refer. As you said, correctly said, there might be foreign bodies inside. I have seen those rubber pieces inside. Yes, 1 or 2 occasions. Yes. Yeah, that's it.
Yeah. In the absence of questions, I would like to invite Dr. Sanath Hettige to hand over the token of appreciation to Professor D.J. Anthony.
Thank you very much. So that concludes day 1 of the 47th annual academic sessions of the College of General Practitioners of Sri Lanka. May I kindly request you to come tomorrow at 7:45 as we have another oration which is starting at 8 sharp at 8. Please join us for some refreshments outside before you leave. Have a good day.